Good morning, everyone. Let me introduce myself. I'm Dr. Sawapak Pongsacitorn. You may call me Dr. Grace from Bangkok, Thailand.
I'm Dong Shim from South Korea. I'm a plastic surgeon. Nice to meet you.
Very nice to meet you. Over a few years, we shift our focus from filling the volume to improving the skin quality. And today, we have an outstanding panel of experts who will discuss about this. Please welcome.
Okay, so we have Dr. Lee Wong from South Korea as the first speaker. He's a very renowned doctor in Korea. He has published many journals. Today, he's going to talk about the injectable skin booster and biostimulator.
Okay, thank you for introducing me. My name is Won Lee, and I'm a board-certified plastic surgeon in South Korea. Uh, he looks much younger, right? We graduated same university, but I'm getting older and older. But to not to be looking so old, I also do the skin boosters in my clinic. So it is almost impossible to overview all the skin boosters in 10 minutes. But I will try my best, and we'll start. This is I wrote myself of articles, and until now I have 80 articles. I'm not a professor. I just like to study, and I just want to make a presentation of with science-based evidence. So I like to make a lots of articles. So we have to think about what is skin boosters. What is skin boosters? These are the biomaterials we are using in plastic surgery. Since there are so many polymers and natural products and observable products and so on. But we always have to think about what is skin boosters. What is skin booster? A lot of doctors says that between the skin booster and biostimulator and the collagen stimulating fillers, right? They are very confusing. The doctors sometimes, for example, they are using radius, for example, because they might sue me if I say a little bit. For example, radius is it filler or is it biostimulator? Why? Oh, I mean, when? Where? We always have to think about this. So what is skin booster? Skin booster is not a filler, right? Skin booster is for your skin, for patient's skin. So we always have to think about that. And volumizer. Volumizer, we says collagen stimulating fillers. But actually, not many collagens are stimulated. But they are saying that. So these are the images of the made by GPT, of course. These days, it is very easy to make this kind of slides. And you can think about right side skin boosters, which is HA, PN, and so on, PRP, or so on. And these are the biostimulators, PLLA, CA, CAHA, and PCL, or so on, right? So these are the biostimulator, we call it synthetic polymers. So I wrote a paper about it, review article, and I'm gonna make a presentation by this. So these are the skin boosters. So natural polymers first. We talk about PLP, PDRN, PN, botulinum toxin, HA, right? So for HA skin boosters, it is a lot of doctor knows that HA is gathers the water, right? It's very good skin booster actually, but it does not prolong well. So HA fillers, HA skin boosters is a little bit not popular these days. And PN, of course, PN is very popular. Room 2 has a session of PN right now. Room 3 also have a session of PN. this PN is quite popular. PN is function is depends on the molecular weight. If it's over the 1,500 kilodalton, then we call it PN. If it's lower, then we call it PDRN. It's two things, only two things that you have to remember is anti-inflammatory and neoangiogenesis. Those are the main effect of PN. So this is they say it's very difficult. Oh my God, it's a salvage pathway. Salvage pathway. Wow, I heard when I was medical school, right? Wow, salvage pathway. What's that? I mean, it's just simple. It's just simple that PN activates A2A receptor and then anti-inflammatory and neocollagenesis. That's the two things that you have to remember. So that's PN. And this is how I do for PN injections. Commercial PN is I'm using is Bitaran for 3 cc's, 3 sessions, 3 weeks interval. So it is very easy to remember, right? 3, 3, 3. It is. And I also use a PN as a needleless injection because I think is that the skin booster should be injected into the dermal layer or the subdermal layers, not into the subcutaneous layers. If you do inject skin booster into the subcutaneous layer, that is not skin boosters, right? That is not skin boosters. So for the needleless injectors such as Mirazet is for the injecting PN into the dermal layers. So I like to use this. And second skin booster is PRP, of course. And a lot of doctors will use a PRP right now. Exosome actually is not injectable, so I'll skip it. And third thing is synthetic polymers. Synthetic polymers, as you know, that a lot of doctors using PLLA, PDLA, PCL, PDO. Those are the synthetic polymers. Okay. So synthetic polymers, we always have to think about observable time, right? This is science, right? It degrades, PDO degrades 6 to 8 months. That's science, right? So if you are using PLLA, it should be observed in 12 months, right? If you are using PCL for the skin booster, then it should be observed like 24 months or like 36 months or so on. So this is very important, actually. You always have to think about the observable time when you're using skin boosters. And the second thing that you have to think about is layers. I always tell to my colleague doctor about this. Because if you are injecting these synthetic polymers into subcutaneous layers, there's no fibroblasts in subcutaneous. Is there any fibroblast? Okay, there might be a little. That fibroblast cannot deactivate collagen, but for example, when I saw that collagen stimulating fillers, I was thinking about why are you using that? I mean, do they really make collagen as subcutaneous layers? Because that's as subcutaneous layers, there are fibroblasts, and stromal cells, and macrophage, right? So, is it really collagen? I think it's fibrosis, right? So you always have to think about layers. Okay. Sorry, but I have to go to the other room for making presentation at 11:30. So when I have finished, I will finish as fast as possible, and then you can make questions. So this is very important table. If you are making dermal layer of the skin improvement, then it is the dermal fibroblast is the target, right? But if you are injecting the skin booster at the subcutaneous fat layer, that is targeting is not fibroblasts, it's macrophage, right? So I think it's a lot of doctors really have to think about these things very seriously. And this is needle-free injectors, and this is the paper. And so there are a lot of biostimulators. We always think about M1 macrophage to the M2 macrophage. So if it should be control. If it's not control, then this might happen. And this kind of complication might happen because it's foreign body reactions. Foreign body reaction. There are so many papers about foreign body reactions. And it's a very old paper and talking about the foreign body, macrophage. So we really, I always think about that, is it really collagen? Isn't it fibrosis? If you think about, you have a fibrosis in lung area, it's disaster, right? But on face, I don't know. So this is another paper. So we always have to think about granular mass, fibrosis, and those kind of complications. This is beautiful implant, and there are macrophage and myofibroblasts. The green one is myofibroblast, and the red one is macrophage. So if you injecting foreign body, this kind of actions always, right? You have to think about, okay? And this is a foreign body reaction. When we do the operation, we can see the fibrosis for after you put the PDO thread after 3 years. So we always have to think about M12, and this is Mirazen. As I told you, I always inject to dermal layers. Okay, this is the last slide. When skin booster is used, we always have to think about focus of the facial layers. For me, I'm using it Mirazen because I don't want to inject my synthetic polymers as subcutaneous layers. And I always think about this M1 and M2 controlling for the foreign body reaction. Thank you.
Thank you, Dr. Lee. There are so many skin boosters these days. He has summarized really well. Since he has to go, do you have a question for Dr. Lee?
No, we will have a Q&A after the session.
He has to leave
Yeah.
for the next session.
Any question from the audience?
Or you can make a question at my Instagram.
Yes. Actually, I have a question for Dr. Lee. So nowadays in Korea, ADM skin booster is really hot. It's the hottest topic. I want to know what your thoughts about it, and do you have you're a plastic surgeon, so do you
Yes.
have any experience with ADM
Yes.
for the surgery?
So ADM is very trends in Korea right now. It's very popular, and it's good product, of course, because skin is thin. Imagine that patient's skin is not very thin, and underneath we are injecting another skin. It's perfect, but the problem is ethical problems, because for me, as I'm a plastic surgeon, I used a lot of ADM for the solid products, like when there's a defect, then for the breast operation, or that we used to use rhinoplasty or so on. But right now, they are injectable. So I don't know. I don't know. It might be ethical problems or religion problems, or so. Let's see what happens.
Thank you.
Thank you so much, Dr. Lee. And please welcome our next speaker, Dr. Sian Lee Peter Peng.
Okay, so, thank you, the chairman. So good morning. It's the last day of the Congress. So I am talking about biostimulator and the HA for the skin quality improvement. So this is my position in different society. I do cooperate with some international society. So the disclosures for this talk, nothing to describe. I presented this concept a couple years ago. So for this talk, it's majorly focused on the skin. So we know the skin quality. What's the definition of the skin quality? There are several papers mentioned about this. We need to take care of the skin firmness and also the skin tone evenness and also the skin surface evenness. And lastly is about skin glow. So there are some components inside marking in the white color. So the treatment options, there are a lot of treatment options as our previous speaker mentioned. We can do like a laser, energy-based device, chemical peeling, etc. And also some of the device, we can use skin booster is another one, biostimulator also. So talk about the fillers. These are very simple, summarize some of the fillers. We have a collagen, we have HA filler, we have a biostimulator. I use this, biostimulator and biostimulating fillers. I think that's a little bit difference. Immediate after injection, you can have fallen. I use these biostimulating fillers. And for the skin quality injectables, there's a lot we can do. The main mechanism is, as a previous speaker mentioned, reduce inflammation and create new collagen formation by this synthesis. That's a PLLA and also PDLA and the PDLLA. They are a little bit different. I use this product especially for the skin quality improvement. We know different layers. We can have a different device to improve the skin quality. By this diagram, you can target just epidermis. And in most of the injectables, we are targeting the dermis. And be careful about the facial loss. There are a lot of publications. This is two of the cases summary in some of the danger area, especially central part. That's some, most commonly the Asian will do the injection. And even the biostimulator, that's a review article, all can happen to cause blindness. So for the HA, for the skin quality, I use this particular product because they have a study to open this channel, aquaporin 3. That increase the skin hydration. And you can see this spatial stain. So this aquaporin 3, that's increase. So you can see with this, by the toxin and some of the filler injection, you can improve the skin quality and especially the static wrinkles. And I use this for the forehead. You can see the before and after. The skin looks smoother, more glowing. And even under eyes, we can use this kind of injections. And these are from one of my publications. Use this HA to improve the overall appearance of the face. You can also take a look. The tear trough also some improvement. And we can treat in like a static wrinkles. This is also from one of my publications. So the dynamic wrinkles, we talking about myomodulations. We also can improve like a smiling lines over here and mirror lines and the perioral lines. This patient just injection over the perioral lines by my colleague. And the skin quality you can see is more glowing after the injections. And this is also after the injection shows some more glowing. So you can see this improvement of the skin quality after injection. So this patient also told me the oil secretion decrease. I checked these publications, you can see they actually can decrease lipid synthesis in the sebaceous gland. They do animal studies, they do in vitro, in vivo clinical study, do shows that. Okay, so this is combined with this HA and with the device HIFU to improve the skin quality. And also we can do the lips. Lips also can be dryness. We can do the lips injection. And the biostimulator for the, that's some related to the collagen, the M1, N2, as mentioned by the previous speakers. That's an important pathway. That's papillary dermis and the reticular dermis a little bit different on the macrophage and also on the fibroblasts. These are some of the publications. This pathway can induce new collagen formation and then have a skin rejuvenation effect. By also can improve like acne scar. This is a histology of the acne scar. They decrease appendage and the thickness of the skin. These are another histologies. So by the PDLA injection, we also can improve that, like skin quality. For this example is improve the skin quality over the forehead and also improve the skin quality, especially over the atrophic acne scar. Another example combined with fractional CO2 laser. This is by the PDLA with fractional CO2. You can see the scar improvement and skin quality also shows improvement. This is another example you can see like that. In summary, I think for different area, we can use some of the fine lines, some of the specific areas, the lips we can use. This skin quality we can use like HA injections. But some of the areas is more favor of the HA, some is more, both is okay, and some is only the HA, like the lips. So don't forget the combinations. You can get hydration, you can new collagen formations. Lastly, I'd like to invite you to Hong Kong, the first weekend this year, ISDS annual meeting in cooperation with True Hong Kong Society. With that, I thank you for your attention. Thank you very much.
Thank you so much for your insightful.
Because I also needed to move to other rooms, if I can take questions if there are questions.
Any question?
Yeah, please.
Thank you very much. So I want to ask something about your presentation. Regarding to your presentation about how you combine the CO2 fractional with the PLLA injection and how you did it.
Okay.
The combination, thank you.
I usually staging. You can be like the HA injection and then spacing by about 2 weeks to a month. You can do the PDLA injections. So increase hydration, increase some of the collagen, new collagen. Yeah.
According to your presentation, you combine two modalities, the CO2 fractional and the PLLA injection. So my question is how you inject PLLA injection after the CO2 fractional or before, and what method do you use?
Fractional laser?
Yes, fractional laser.
Okay. You can do on the same day, especially for improvement of the atrophic acne scar. You can do the needle-free injector. So to improve they have some dissection of the fibrotic band and also can improve by the new collagen formation.
Thank you, Dr. Ping. I want to ask you a question. So to clarify, what kind of product do you use for PDLLA?
the Juvlook.
Juvlook. How do you use it? Do you use it by manual injection or a needle-free injector?
Yeah, I usually by manual injection, by the needle, just needle injection. Yeah.
And can you tell me the depth you're
Depths,
targeting?
I will keep on the deep dermis or subdermal layer.
Thank you so much.
Thank you.
Okay, and please welcome our next speaker, Dr. Sonia Sattler.
Hello, hello everyone. Well, wonderful I'm here, and thank you for having me again in Bangkok, MCAS Asia. So my background is about biostimulation about 20 plus years. And now I'm in my 29th or already 30th year of my clinic. This is Germany, my clinic. And I have had contact to PLLA as well as CAHA in 2006 already. So, you know what happened recently in the world is we all think overfilled patients can be seen everywhere. We see it with celebrities. And all HA is bad. I think that's not true. It's a mistake of the doctors to inject too much to the patient, and it's not the HA fault. So now, at least I see that in the world, because I'm traveling, giving lectures everywhere, it's really a mistake to replace HA by biostimulations. It's a complete different thing. So don't think you don't need HA when you do biostimulation. I think that's the first thing. So I also started with volumization. I did the same mistake as you, and everybody did in his life, because the patient come in and always want more. But your first picture of the patient is your best friend. So picture taking is crucial. No patient will even see me or talk to me without taking a picture before. That's one of the lessons you can learn today. And then, of course, your personal assessment should be correct. And you have to assess also manually. You just don't watch only. Touch the skin and you will see we have really thin dermal layers to touch thicker dermal layers, connective tissue loose. Then maybe the HA will blow up. The biostimulation is better, but with no volume. So there's so many things to talk about, and then I think about myself, in which layer did this patient age the most? No matter if she comes in for skin booster, maybe she needs something else first. Okay, maybe the dermal layer has to be tightened, like skin firmness is one of the major parts for good skin quality. So, and then of course you develop a treatment plan and then you offer it to your patient. So you do a diagnose first, please, and then decide what you can treat with in your portfolio. And this is now an Asian consent on CAHA for biostimulation. And I would love to really take you on the journey about biostimulation and use it respectfully. I have seen so many mistakes, but you see, it can have beautiful results. But it is like it is. Asian skin is more inflammatory. Asian skin is more reactive. We have to be honest. And the publications are usually in Caucasian skin. So everything what's written in there, reduce it by half from the first, okay? And then you have to educate your patients. The patients come in and want a result immediately. There is no immediate result in biostimulation. No, that's not possible. They have to wait for it. It takes weeks, months, and it will go on more and more. So my key consideration is, I want to have a safe product, and what do I want to deliver to my patient, and what is my assessment and my diagnosis. So, because I want to have my patient with me for long term. Because if you deliver good results, they will stay with you, they will trust you. So we have to understand fibroblasts a little better. You know, fibroblasts are really these cells who are part of, or have the biggest part when we age, because they act less, they go to sleep. So we have less fibers homeostasis, we have less fibers produced, less elastin coming. So but it's responsible for so many things. It's a nice little guy. Look at this. Looks good. And it really does produce collagen, elastin, proteoglycans. It's super important to have this function active, this fibroblast. But it needs the attachment to fibers. And if the attachment to fibers isn't there anymore, because you might go into menopause, you get looser connective tissue. You might have, UV damage. You damage the fibers. Then less fibroblasts will be active, and then they get this shape. They are round and not functioning anymore. So for me, it's very important for you. You should understand we want to keep up the function and structure of our fibroblasts. And this is not so easy. How do you activate them? Look at your hands and feet. Where you put pressure on, fibroblasts act more. So they are mechanical guys, okay? So the mechanical stretch, we always say, activates fibroblasts. But also inflammation activates fibroblasts, or even metabolic. We have diseases in dermatology where too much fibers are produced. Too much fibers. It's an old slide, but I love it because it shows you, with no further treatment after CAHA, your fibers will improve, get bigger, thicker, over weeks, 78 weeks. And after 4 weeks, it's not there yet. So you have to educate your patients and not redo the treatment. I think you should be very respectful with amounts in biostimulation. The outcome and the result, and this is a publication by Tatjana Pavicic, is your own tissue, a thicker dermal layer. And this is what we want to achieve, but not too much. We don't want to have a fibrosis. And I do disagree a little bit with our first speaker, because there is a publication out last week, actually, showing that CAHA can induce a thicker, nicer dermis if you inject subdermally. Please read it. It's Gabi Casabona again, as well as Neve Korov, she's next door. So, but the particles are different in biostimulating agents, and you need to understand that, because the particle size matters. So here you have CAHA CMC, which is radius. Next one, CAHA HA, which is harmonica. Next one is CAHA PEG, which is Novia. And the last one, the flaky one, is the Sculptra. So, of course, a more rough surface will really induce more inflammation. So I had my first experience with PLLA Sculptra in 2006. And I would never touch it again, because we used it a lot in HIV patients. And HIV patients, it was on label at that time. We had wonderful results, wonderful, but they had a different immune system. The minute we induced the PLLA Sculptra with a rough surface into an immune competent patient, we couldn't control it anymore. It did function, of course, but the control was not with me anymore. The pro-inflammation part of the shape itself I couldn't control it. So in my hands, it's easier to control CAHA, but it's about amounts. So this is, the pathway. It stimulates with the foreign body reaction. That's an official charge of the company at the moment. And this is when we use it for HIV patients, PLLA. It was fabulous. And it's not a bad product, but it's about amounts and controlling what you want to achieve. We want to go more the regenerative process today. So in my hands, I can deal better with CAHA in a diluted version and not too many times. There's a rule, 1 package per year per 10 centimeters square, not more. So the metabolism you probably know all, and then we know that the volumizing is different. The rheologic properties change when you dilute products. So for biostimulation, we don't want to have any volume. We just want to have more function of your cells. So use it respectfully. We want to have it regenerative, okay? So we don't really want to give volume with biostimulators. I came across this study, which is really a new one, and I want to really address that to you. If you are respectful with biostimulation, This is a study about burn scars. You can really remodel even and get back the function of your fibroblasts of, wait, I can go back if you want to take a picture. You can go back and you can really induce the function itself. So let's do it a little faster. I want to share with you that fibrosis stays over years, okay? So it's a long-term thing. You induce a long-term thing with biostimulators, and you can have a lot of problems if you do the inflammatory pathway. So there's a consensus how to inject and dilute CAHA since many, many years, and I love this consensus because I think it's still true. You know, on label, it's in Europe only for the décolletage in a dilution 1 to 2, but I think it's amazing how you can use it in body areas. It's my best tool for body areas, arms, abdomen after pregnancy, legs. And I do love to combine it. There's also science to it in the background with microfocus ultrasound. And again, you do it in one session and wait, don't do more. Here from Singapore, Silvia Ramirez did this study on arms, published it very nicely. This is what you want, skin quality. You give the base with the dermal layer for good skin quality. This is one of my patients in the combination CAHA and microfocus ultrasound. So it's predictable, but this is my mistake and I want to share that with you. She came in for skin quality of the arms and I gave her too much. She came in after 3 months and I gave her another package. And then we did microfocus ultrasound, and then she went to the spa and had all this non-invasive RF, and then she came back in 1 year. And she said, oh, my skin is nice, but now I can't go into my jacket anymore. So I volumized her over time, and I gave her only 2 packages. So be careful, we have a whole orchestra to play with. Biostimulation is only one of it. Fibroblasts, we want to keep up the function. And my take-home message for you is all biostimulation filler act long-term. You need to know your product. And you need to really adapt your product to the patient needs, amounts, and the result will stay the patient's own tissue. Okay, and this stays long. So the mode of action differs, as I showed you. And then, of course, we want to work with our patients long-term, so biostimulation is once a year in my clinic for my patients. I think CAHA is more versatile. Still, it has issues. You have to be careful with the dilution. Your nurse have to help you correctly, so you have an even distribution. And yes, there is too much with all products if you want. You have to use it respectful. Okay? Thank you so much. I want to invite you to ISDS also, Hong Kong.
Thank you so much.
And these are my contacts. Thank
Dr.
you.
Sadler, please stay with us.
I
on
will
the
stay
stage.
there if you don't mind. I come back up.
Okay, please welcome our last speaker, Dr. Punyapat Sirithanabadikun.
Okay, hello everyone. It is my pleasure to be here today. And my topic today is because there is some question being raised that does injectable biostimulators that we use in everyday practice is as a truly scaffold? And injectable CAHA can serve as the scaffold. So my topic today, I would like to revisit the concept of the scaffold and does injectable CAHA fit into that things? Okay, so for the traditional tissue engineering scaffold, it have like a ideal properties, which has 4 main pillars. The first one is the surface properties. The surface property, it should mimic the extracellular matrix, which is large and open pores. And secondly, the geometries of the structures, it should have the porous template and interconnectivities. And thirdly, it should have the mechanical strength that can resist the deformation. And lastly, it should compatible with our tissue. CAHA is one of the regenerative biostimulators. It composes of 30% of the CAHA particle suspended in the 70% of the CMC gel. So in the next few slides, I will address the key principle of the scaffold, and I will see how CAHA not fit into that properties. So the first pillar of the tissue engineering scaffold is a surface property. We should have large and open pores. We have to distinguish between the tissue engineering scaffold and the CAHA particle. The tissue engineering scaffold has like a 3D rigid and solid interconnected porous structures, while CAHA acts as the dispersed particle scaffold. This dispersed microsphere creates a favorable environment that can guide the tissue regeneration and integrate with the host tissue naturally. And the CAHA scaffold, the space between the microsphere is act as a pore. So the optimal distance between the particle is very important for the neocollagenesis because it allows cell to attach to the particle. If that particle is close and densely packed, our fibroblasts cannot attach to that particle. So the CAHA, this study showed that the CAHA has sufficient distance between the neighboring microsphere to allow the fibroblasts to attach to the particles and then cause the mechanotransduction signal. And the next property is the appropriate size and rigidities of the particles. So CAHA has symmetrical, smooth, and no hollow particle or defect. So it causes less immune reactions, and the size that's strictly between 25 to 45 micron. I think this is like a sweet spot for the size because it's not too small to engulf with the macrophage, and it's not too big to trigger the granuloma formation. So it's like a Goldilocks that just right there. And the next property is the rigidity of the particles, because when it has a rigid particles, it can resist to the deformation and it can physically stretch our fibroblasts, and then fibroblasts sense that stretching force via the integrin receptor, and then it stimulates the YAP-TAZ pathway for the mechanotransduction effect. Apart from the mechanotransduction, the calcium also acts as the biological cues because during the degradation process, the CAHA degrades to the calcium and phosphate, and that calcium binds to the calmodulin receptor and represent the key biological cues in the tissue regeneration, and it's functioning as the secondary messenger to activate our fibroblasts. The next property of the scaffold is ability to mimic the extracellular matrix. In the youthful skin, the intact collagens provide the mechanical stimulation to the fibroblasts, keeping them active. But in aged skin, the fragmented and disorganized collagen leads to loss of contact, the mechanical support to our fibroblasts. This loss of the mechanotransduction make our fibroblasts senescent and less active and stop to produce the collagens. CAHA can restore this mechanotransduction signal because the CAHA particle acts as the extracellular matrix that allows cells to attach, and then it stretches our fibroblasts, and then our fibroblasts become active again. And this research addressed the CAHA that can significantly increase the contractile force of the normal and wrinkle fibroblasts, and it can restore the contractile force of wrinkle fibroblasts back to the level of the normal fibroblasts. The next property is the geometry, which should have like a porous template and interconnectivities. As we mentioned earlier, the space between the CAHA particle is mimic a pore, and it acts as a pore template. And this CAHA particle is suspended in the CMC gel, and CMC gel has the unique character that it has high porosity, so it can imply like interconnectivity. So the CAHA that embed in the CMC gel is imitate the porous interconnectivities of the traditional tissue engineering scaffold. The next property is the mechanical strength of the scaffold. CAHA is the one of the product that has highest G prom and highest complex viscosity. And one-to-one dilution has highest property for the neocollagenesis. Although the CAHA in CMC gel does not provide sufficient mechanical strength to function as the tissue engineering scaffold, but the CAHA particle itself remain intact under the mechanical force. It's not like a breaking apart when it has some force to the particle. So, and for the injectable formulation, it allows the product to inject into our tissue and integrate well with our extracellular matrix. The next property is the biocompatibles. It should be non-toxic and compatible with our cell. CAHA is nearly identical to endogenous CAHA because it's like a composition of our bone and teeth, and it used as biomaterial implants for a long time. It usually remains in our body around 1 to 2 years, and then it degrades through our biological process. Through the mechanotransduction and the biological cues of CAHA, made the CAHA is the one of the regenerative biostimulators, and there are many studies to show and to demonstrate the efficacy of CAHA. This is the first study that showed the CAHA can regenerate the collagen type 1, type 3, elastin, angiogenesis, and also the proteoglycan. It's not only induce the collagen production, it's not only like induce the things or our extracellular matrix, but the thing that they induce is make our skin back to native and healthy skin. So this one showed that after we inject the CAHA into our skin, the skin thickness was increased and our elasticity and pliability also significantly increased too. So I think to summarize, I believe that CAHA is like a cellular particulated scaffold, even though it's not equal to like a traditional tissue engineering scaffold because it doesn't have rigid 3D dimension matrix, but it can support like a border the functional support to our biological process. It supports our fibroblast activities, it can support the neocollagenesis, and also it can support our dermal regenerations. The presence of CAHA particle can promote the fibroblast recruitment and activations, and it supports the neocollagenesis, the elastogenesis, the proteoglycan productions, and angiogenesis. We can observe the new type 1 and type 3 collagen associated with the CAHA microsphere. And CAHA microsphere stay in our dermis long enough until the process is finished, and then it will gradually degrade through the biological process. Thank you.
Thank you so much for your presentation, and I will have the speakers up here and start the discussion. Please. So do we have a question from the floor? Please, okay, we'll start with the doctor.
I have a question for the user of CAHA. We know there are two brands of CAHA, the blue brand and the green brand, right? Two brands of CAHA, right, that is available in the market. The blue brand that we all know that has 30% of CAHA, and the green brand that claims to have much more CAHA, like 55 or 60% or something like that. Would you say...
Which brand you use?
I'm using only the blue one.
Yeah, but you know, that brand claims
What is
to
the
have
green one?
green
Which is the
one?
green one? Tell me.
Novuma.
We don't have.
Novuma
We don't have.
claims to have a 60% CAHA. Can you
ได้ค่ะ
theoretically
ชุดเป็น
comment
เรซิน
if having more CAHA actually result in better results?
No, I just try to tell you it's easily too much. The regenerative process is only when you have best in a one-to-one dilution. If you have more, we don't want more. Why?
Okay.
So we don't have this product in Europe, but at least not in Germany.
Okay.
So, but I don't want more.
Okay.
I don't have that product too, but as I mentioned that the optimal distance between the particles is very important for the neocollagenesis because if the particle is like a densely packed, it's not allowed cell to attach. So maybe it might more or less, we cannot sure about that.
Okay.
But
thank you.
yeah.
Yeah, so that's so important because the even dilution is the key element for a good outcome. And the even dilution is not easy to do. If your nurse is preparing your syringe and you talk to the patient 2 minutes, it's again separated. So you have to kind of dilute it again. And to keep the nice microspheres, the dilution is not dung, 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 dung fast, it's smooth, okay? Keep it smooth. So you want to use the best properties of this CAHA.
All right, thank you.
Dr. Sonia, regarding that, I want to ask you too, how do you dilute the CAHA in your practice? Can you please
So
share?
I have to be honest with you, my highest dilution is 1 to 3, and this is only in body areas. I can tell you why, because the longer or the higher you dilute, the more of the CAHA particles will distribute through the fat tissue. They get lost a little bit on the connective tissue till the fascia. If you want to address the fascia, which is normally stronger, which you don't need, but the connective tissue, I take a dilution of 1 to 2, in a bigger area 1 to 3. But in the best, you can do 1 to 1. But even in a Caucasian neck, for example, 1 to 1 is sometimes a little bit too much.
Also agree with you that it depends on the area that we use and also for the skin thickness too. Like if I use for my patient's face, usually I use like a 1 to 1 dilution to 1 to 2, depend on the thickness. But if we use for the body, I also dilute as her like a maybe 1 to 3, and in the neck sometimes 1 to 4.
Yeah, the neck can be very
Yes,
thin.
it's very tricky area.
But 1 to 3 is enough, I think.
Oh, we will have the lady first.
Okay, thank you very much for the chance you have given me. Okay, so after the biostimulator injection, but I'm not mentioning about only the CAHA, but also the other biostimulators. So my question is, in some patient, after being injected with the biostimulator, the patient experience a thicker density of the skin. But in some patients, they experience a more volume of the skin. So my question is, does the biostimulator contribute to the adipogenesis or only just stimulate the collagen itself? Thank you.
So very good question. So is there only collagenesis or adipogenesis?
Okay, so we don't really know, I think. And we have to be honest that with the improvement of the microcirculation through angiogenesis, you probably have also a better working stem cell in the fat. So, but we have no proof of that yet. But this is probably why it volumizes a little more. So that's what I wanted to show you with my mistake in the arms. It keeps on going. You know, it keeps on going, and if you add more, it keeps on going too much eventually, and then you have volume, which you don't want.
Please.
Okay, my question is, in patients with thin-edged skin, what is your preferred dilution ratio of CAHA to optimize biostimulation while minimizing the risk of nodules or irregularities?
My dilution is 1 to 2.
1 to 2.
Yes, me too for the face, 1 to 2.
Hello, doctor. I want to ask about hybrid treatment. We know that some doctors hybrid or mix the CAHA with other skin booster, especially the hyaluronic acid skin booster. What do you think about mixture about hyaluronic acid skin booster and also CAHA?
Actually, I used the hybrid, but I didn't combine CAHA with the non-cross-link HA. I combined CAHA with the cross-link HA because we combine the CAHA with the cross-link HA because it adds more benefit, many things for these hybrid formulations. Because we know that if we use the CAHA, the CMC gel will go in the 2 or 3 months. So if we mixed with the HA, the volume will not gone after the CMC gel was like a resolved. So that's why we mix with the HA, and it can like easily inject, and like actually it has some study to show that it can create more the collagen's production. So I didn't combine with the non-cross-link HA because it might not produce the benefit that we want.
Okay, I have left hybrids completely because I think I can do both in one session, but conduct the product into the right layer and the right rheology. Because I've seen in especially thin skin, combining also with a low cross-linked HA, that the CAHA particles have not distributed well, and then nodules occurred. So I completely left this. I think it's a phase. And I think also what is published, I mean, you have to look at the patient population, how thick the skin is there. So why do you want to take the risk? I don't understand that really, because I think we get into risk of non-distributing correctly the CAHA microspheres if we have it not in a proper dilution, because we don't know if we have it in a proper dilution with a cross-linked HA. So I'm maybe one step ahead. I think many of us have left this period in between already.
So it means that you don't mix it together, but
No.
you inject in the different layers.
Different layers, like deep the HA on the bone, for example, if you want to volumize. But then in the subcutaneous, the diluted CAHA stays by itself. And if you want to do intradermally or epidermally, superficial, what Peter Peng said, with any skin booster, you can add it on top even if you want. But don't mix it, because the CAHA particles get not distributed correctly.
And I have a question for Dr. Sadler. In your experience, what is the early warning sign for the over-treatment before it becomes clinical?
I have to be honest with you, we don't know. So I share with you this why I'm not with PLLA, and I see now products in Europe coming out, microspheres PLLA, which is interesting, but let's have the studies first. Okay, I cannot comment good or bad at this moment. But with the other one, with the flaky shape, I've injected my husband at that time, 2008, and he passed away 4 years, and until then he had a fibrosis block in his face, and we both disliked it so much, and I think he was a kind of reactive guy, immunologic, so I can't control this, who is the right or who is the wrong, and it was only one vial, not on. When I think about 3, I'm sweating.
So, Dr. Sadler, you are not for the PLLA because it induces too much collagen for some patients.
Yes, too much, and also late onset granulomas. I've seen that so many times.
I think that sometimes we think that we can control, or we say that it's like a controllable inflammation, but actually it's not controllable like that.
Inflammation is not controllable, and we have patients with allergies and non-allergies, and they are so different. I think we are just in the kindergarten with biostimulators, to be honest, because we know now how things might combine. Environment, maybe supplements help additionally, maybe only heat in the spa, whatever they do, the patients adds on. So we are just learning, and we want to have a smooth and regenerative approach. We don't want to have aggression. But the patients, of course, sometimes are very impatient. They have to learn that it takes time.
Okay. So, Dr. Sadler, in the case of over-volumization, do you have any remedy to cure it?
Not really. So we discussed that yesterday already. I think nodules which are not inflammatory, you can in the CAHA version you can easily disrupt with saline in the first 2 to 3 weeks. So your patients need to be educated. Like if you feel a nodule in the neck area, especially, come in. We can disrupt it. If it's too long going on, you can't. We know that these nodules will always fade with no further treatment, always, but it takes sometimes months or even years. Other inflammatory nodules, of course, we discussed short onset oral corticosteroids. We discussed 5-FU triamcinolone into the area. There we said yesterday, and we agreed on that actually, it's a version to, it's possible, but you need to understand that this will reduce tissue maybe around your nodule. So in the long run, you will have then a little dimple, which you have to add on with the HA again. So it's not so easy. Better to do it in a systemic way, probably, to start with. But if it doesn't stop, you need to go locally as well.
Okay.
Thank you.
Another question for Dr. Punyapat. What indication you think is uniquely suited for CAHA compared to PLLA and PDLLA?
I think if you want, you mean for the face, right?
For the face or body, up to you.
Actually, I like you that I didn't use PLA in my practice, and I think if patients want the regenerative process, they want to restore the normal and like a healthy skin. I think that's a very unique characters of the CAHA.
Thank you.
Okay, so time's up. Thank you
Can
so
I
much
ask
for
one
your
more
presentation.
question? Just one more question. I'm
Okay,
here.
okay, last
Yeah.
one.
I just want to ask if there is a standard protocol for your opinion regarding the frequency of the injection with the CAHA. Like, some products, like for instance, I don't want to mention brands. They say you have to do it once a month, every 3 months. So in your opinion, what would be a standard protocol? And my second question is supposed to be for the doctor who spoke a while ago. I'm not too familiar with ADM, so I'd like to be enlightened a bit. Where do you position the ADM? They mentioned something about ADM. So I had 2 questions. Thank you. Thank you.
Okay, so first, what's the frequency of the injection for CAHA, please?
So for me, I think it doesn't have any like a standard protocol that you have to strict with it, because it depends on the patient. Usually when I treat my patients, after I inject patient for the first time, I usually evaluate patient 1 to 3 months. After that, does patient still need, or does they still have skin laxity, or the skin, does they need more or not? And after that, I will repeat every 1 to 2 years after that.
Yes, so I have quite a clear rule. I will see my patient back after 3 months. Okay, and then I write down this is gonna active. It shows slightly results already. Then I will leave it. If I see nothing, especially in body areas, nothing same as before, I might add a little bit, not a full package. But my rule is 10 to 10 square centimeters, 1 package a year. So then we do the next, especially for the face, the next package, right or left cheek, next year.
And for the second question, so Dr. Lee talked about ADM, which is acellular dermometrics. They come from the human cadaver dermis, and we decellularize to remove the immunogenicity. And right now, it's a very big trend in Korea. It's used for skin booster and volumization. I think it's great because it can work as a scaffold, and when it breaks down, it gives a cellular signal to generate collagen. So Dr. Lee, the first speaker, talked about the ADM.
So I'm not familiar. I know about it, but I have never used it, so I can't comment.
It's just coming to Thailand, but I think it's not spread, and we doesn't have experience with that yet.
Okay, so we're going to wrap up the session. Thank you so much for your presentation.
Thank you so much.
Thank you so much. Thank you.